and welcome to this presentation. My name is Purva Abhyankar. I am from the University of Stirling in the UK. I'm going to share some insights from our recently completed study. The study aimed to implement pelvic floor muscle training for women with prolapse through different delivery models, and we use a realist evaluation approach. So pelvic floor muscle training, which is PFMT for short, is a treatment delivered by a specialist physiotherapist, and this has been shown to be effective for female prolapse. However, access to this treatment is limited in the UK as well as globally because there is just not enough number of specialist physiotherapists to deliver it. So to increase access, alternative models of delivery are needed. The PROPEL study aimed to maximize the delivery of PFMT using service models which involved training different staff skill mixes to deliver the treatment. We wanted to know if these models are feasible in the NHS, whether the outcomes are comparable to those achieved by specialists, and what the barriers and facilitators to implementation may be. And we conducted an outcome evaluation and a realist evaluation. Here I report on the realist evaluation only, understanding what works for whom, in what contexts and how. We used a longitudinal multiple case study design with qualitative methods. It was informed by Pawson and Tilley's realist framework as well as Russell Glasgow's RE-AIM framework. The study took place in 5 purposively selected very diverse NHS sites, 2 in Scotland and 3 in England. Data were collected from a range of stakeholders using focus groups and interviews at 4 time points over an 18-month period. And data were thematically analyzed to understand how and why the implementation worked or not, and in which contexts. The emerging context mechanism outcome patterns were mapped onto the 5 indicators of impact from the RE-AIM framework, and I present the 3 most relevant to health services research. So first, impact on implementation. Now, in contexts where specialist physios were in shortage and PFMT was quite inaccessible, particularly in remote and rural areas, there was a heightened awareness of service needs, which enhanced staff readiness to extend PFMT service to the community, train different staff, and initiate workarounds to make this possible. However, in areas which had an established PFMT service and a seemingly adequate capacity, PROPEL intervention triggered perceptions of threat to the specialist role and protective feelings, resulting in resistance to a community model and to training lower grade and other staff. Impact on reach. The access to PFMT widened in areas where the staff and management had a keen interest in pelvic and women's health and had already started training other staff to increase capacity. In these contexts, training delivered within the PROPEL enhanced staff knowledge about prolapse and their skills and confidence in assessment and treatment. Particularly, this was the case for general physios and nurses. This led them to become more holistic in the assessment of pelvic issues and proactive in providing treatment and extend it into the community. However, in some areas, community models didn't work as well, where nurses didn't have the prior experience and training in pelvic health and lacked in-depth understanding of physiology. PROPEL training was felt inadequate to fill the knowledge and skills gap. This lowered their confidence and led to withdrawal. And finally, impact on adoption. Implementation of the new models was seamless when support was made available to the newly trained staff to incorporate PFMT delivery in their role and core work. However, when such support was lacking and coupled with delays in implementation, PFMT delivery was seen as an add-on and low priority, resulting in service disruption. So in conclusion, the study showed that PFMT can be successfully delivered using a range of staff skill mixes and in different NHS settings. These models are more likely to be successful when delivery is undertaken by clinicians with an interest in women's health and are carefully implemented, ensuring adequate levels of training and ongoing support. And this support should be from specialist physiotherapists, multidisciplinary teams, as well as the management. Feelings of role protection among the staff, the specialist staff are likely, so these need to be carefully managed and balanced with the population needs. Thank you for listening. If you want more information, you can contact me on my email, or you want to know about our forthcoming publication. Thank you again.